Hi, welcome to Guts and Glory, the podcast which delves deep into the complex world of gastrointestinal and HPB disorders. Join me every month, wherein we unravel the mysteries of these complex issues in candid conversations with leading experts who share their experiences, tackle contentious topics, and provide cutting edge insights. I'm Sadiq Sikora, and this is Guts and Glory. Today, we have a special guest. My guest is Dr. Parul Shukla. Now, Parul, a lot of people would know from India how he has contributed to colorectal surgery. Parul is the product of the Mumbai School of Medicine, having graduated from Grant Medical College. And he served at the Tata Memorial Hospital for more than a decade, leading the GI surgical service. He moved to the US in 2011, and US's gain was India's loss. He worked at several reputed academic institutions in the US, and currently he heads the Northwell Health Regional Colorectal Cancer Surgery Unit and is also a professor of surgery at the Zucker School of Medicine, Northwell. Parul is a great teacher and he is a prolific writer. He's published several articles in peer-reviewed journals and has contributed to many chapters in textbooks. He's also edited a book on colon and rectal cancer surgery. So, Parul, welcome, good morning, and I'm delighted to have you here on this podcast.
Thank you. Hi, Sadiq. It's been really nice to connect with you. And thank you for inviting me to your podcast. I've been following all your episodes so far, and they've been tremendous. So I'm really honored to be included in your guest list.
I
You and
also want to tell the audience that you have started the Surgeons for Surgeons. It's a app-based, meeting place for surgeons to share their experiences and uh, cases and problems and discuss all of this. Am I right? You want to say something about
Sure.
that?
Yeah, thank you. So you can see my backdrop. It's Surgeons for Surgeons. It's an app only meant for surgeons and surgical trainees. So if you are a surgical trainee or a surgeon, we welcome you. Please join. You can download the app on the App Store or the Google Play Store. But this podcast is not about Surgeons for Surgeons.
Some
So
other day, some other day.
yes,
What
yes.
I want to know with Parul is a couple of things that what made him move to New York, leaving Tata Memorial Hospital in India, and how he's established his practice and expertise in colorectal surgery.
I had a really very, very good stint at the Tata Memorial Hospital. I call it the Tata Cancer Center. And, I was very privileged to work there for a decade.
Yes.
And long time in that decade, I also led the GI team. Um, I think it was a decade of so much of excitement when minimal access surgery came into the cancer world. And I remember performing amongst the first few, laparoscopic cancer surgeries in our country, doing that with trepidation, especially when we did some gastric cancers and the worry about port site recurrences were
Right.
not insignificant. The way things developed for me is that towards 2009 and 2010, that was coming to a decade being at the Tata Hospital. But I still had some desire to be part of innovation. And when I got an opportunity to come to the United States, first on a sabbatical, it was mainly to pursue some technological and technical innovation. And I was here temporarily for a year,
Mm-hmm.
2000
Yes.
to 2011. And my hosts at the Weill Cornell Medical Center were very pleased with the year, and when it was time for me to go back home, they offered me to stay back. I returned to India for a few months, but then my hosts here in New York were very serious. They sent me a contract. They were calling me, they were encouraging me to do that. And I was at that phase of my career where the next step up at the Tata Hospital would have been I would have been the chair of surgery. And that actually frightened me because I felt I was a little too young and I had too much of innovation within me at that stage to start doing a lot of
Certain
administrative work.
administrative responsibility. Yeah.
And so that's when I decided to move to the US. So
So how
that's
has
how it.
it been?
So, I've been very fortunate. I've really worked in these really major teaching institutions and big organizations. So whenever you are either I was at the Tata Hospital or at the New York Presbyterian Hospital in my previous job, and now at Lenox Hill Hospital, the hospitals within themselves are really very similar. Obviously, even though I was an experienced surgeon and I had a lot of confidence behind me, over here I was starting afresh. And I had never
Yes.
worked in the US. I have never trained here. So for me to start working as an attending and also start functioning and performing at the levels which you are expected to do was an initial, it was daunting. So that's really been my career, pathway so far. And till today, I always stay very focused on my cases which are to come. So next week on Monday, today is a Friday night here in New York. On Sunday evening, I will again refocus my attention to the week coming and study my cases,
I mean, all
make
the
sure.
thing which keeps on coming to my mind is you picked colorectal surgery at a time when it was not that, let's put it, glamorous or the in thing to do. So tell me, the thought process that you picked colorectal surgery and you made that your career choice and just focused on that. You know, Tell me how it came about and what was in the background of all this.
That's a great question. So, as you know, when I worked at the Tata Hospital and the GI surgical oncology, almost half of my work was non-colorectal. It was HPB and gastric. And, being given the responsibility to lead the service, I had really focused my energies on almost all these sites, and we were doing well among all of them. Uh, Within colorectal, the fact that minimal access surgery had really penetrated deeply first and had taken off was clearly a very important point for my interest. And then moving to New York, being as mature market as New York is, you really can't be a specialist in every aspect of the GI tract. The new thing which I got exposed to here was really mastering the endoscopic techniques. I had in India, we as surgeons don't really do colonoscopies, but that was an
Yes.
aspect which I very quickly learned. Very
Okay.
complex removal of benign tumors, also pushing the envelope in trying to avoid surgical resections as much as possible for benign
Yeah.
tumors as possible. So, with my group and my colleagues at Great Partners, we worked hard to develop techniques. We published on our combined endo-laparoscopic surgical procedures. I was part of ideating and also working with early adopting a new oversheath for the colonoscope, which really empowers the endoscopist to push the envelope in what you can achieve.
Since you mentioned this endoscopy thing, uh, clearly you believe that surgeons should be doing, but that's not the case in India. So you think surgeons doing these procedures is better?
So I don't know about better, but I can't think of a single urologist who would refer their patients to a nephrologist for a cystoscopy. So, using that as an analogy,
That's a
uh, I
smart argument.
yeah, so I can't cede my space to a gastroenterologist to do colonoscopies if I needed to do it. I'm not saying I want to do screening colonoscopies
Yeah.
or I want to do
Yeah.
run of the mill, but as and when you need to do it, we need to have that capability. And if you will only have that capability if you do it again and again, you can't do the occasional one and then try to do a complex procedure.
So, Parul, you've been in colorectal surgery and colorectal cancers you've been treating over these last 1.5 decades or so. Uh, Tell me philosophically, what do you think are the key things which have evolved over this decade or two and has brought about a paradigm change in how we deal with colorectal cancers? I mean, like, a overview, a couple of things, one, two, three, you think have made a great impact.
So I think, one thing which was very different in my practice here in New York as compared to back in Mumbai was that certainly I was seeing more stage one and stage two cancers as compared to back in India, where we were seeing more stage three
Yes.
and, of course, the stage fours, unfortunately. So that really was an eye opener to me that there were cases where I was even trying to be sure that, oh, is there a
It's
tumor
a
in the section
malignancy.
I'm going to
Yeah.
take out? Because
Yeah.
in India we were always able to see or feel the tumor. There was no question about it.
Yes.
And
Yes.
here, when you're doing it laparoscopically, and if there is no tattoo, you're really relying on the fact that somebody has accurately positioned that tumor for you. So that was a big difference. And I think that in part answers your question that outcomes from operating on early cancers is really the key. And I think,
Outcomes have improved tremendously, isn't it? Like even for metastatic colorectal cancer to liver to lungs. I mean, there was an era when we would sign off these patients, but now we know that even in metastatic situations, we can get good outcomes. Uh,
yes. And
but understanding of the disease has also improved. And some uh, phenomenal inputs have come from understanding the molecular signatures of these tumors. But we get, most of us get lost in this business of KRAS, NRAS, RAF, and all that stuff. So I want you to sort of take us through this maze and just crystallize that what do these markers, what are the important markers, and how do they suggest to us that how they will behave and what approach does it chart out based on the molecular markers.
sure, I think it's a very important question. And as surgeons who treat cancer, it's really important for us to understand the biology behind these cancers. So when I look at the biopsy results from a colonoscopic biopsy, for example, the one thing I'm really looking for is the mismatch repair gene status. So the MMR really is your first window into whether you have opportunities to understand this. Is there a background reason for the cancer? So, for example, if the mismatch repair genes are proficient, then it's highly unlikely that there is going to be a genetic component for that cancer. But in
Right.
patients where you have MMR deficiency, then you're looking at certain opportunities to use immunotherapy, etc. So, really speaking, MMR is the surgeon's
First
first
step.
port of call to understand how you're going to treat these cancers. The second is more relevant in the metastatic setting, the ones you mentioned, the RAS mutation or the BRAF mutation, the HER2 amplifications, because these are going to guide the medical oncologists to choose the type of targeted therapy they may be able to use. So it is less significant for a surgeon, but more significant for a medical oncologist, especially in the metastatic setting. Along with the MMR deficiency, we are also talking about the POL and the POLD1. Again, these are, the DNA repair deficiencies, which again give opportunities to immunotherapy. So these are the basic sort of ideas where surgeons should have some form of an idea when your algorithm starts to treat patients with cancer. Where does that algorithm really begin when you're looking at these markers? And I would certainly recommend for everybody to understand the MMR status. If your pathologist has not reported it, then that's something you want to know.
Right,
I would push that report a little bit more, ask them to give you that status.
right, right. Uh, that famous New England Journal uh, publication, which sort of created a sort of storm, and it was in public domain, and newspapers carried that now colon cancer can be
Yeah, I
cured.
think it was a breakthrough study. It was quite remarkable because this was mainly used for patients with rectal cancer. That was the study. And this was for MMR deficient patients. So this is basically called a checkpoint inhibitor. So the PD-1 is called programmed death. That's the inhibitor you want to use, the PD-1 inhibitor, docetaxel. And the remarkable feature was that in those 7 or 8 patients in which it was used,
Yes,
every patient had a complete
response.
clinical response, and that response has sustained over a period of time. So that was quite a dramatic, breakthrough. 10 to 15% of tumors at the higher end of our approximation will be MMR deficient. So it's likely that the numbers are small,
Yes, very
but
select group.
certainly, yes, but certainly if they are MMR deficient, there is a real opening with immunotherapy.
So there's another area about colorectal cancers which has come up, and now we are seeing very young people with colorectal cancer. Earlier, it was a disease of the elderly, and now we see, and also sometimes they come with very advanced disease or rapidly growing disease. So I want you to comment on that. And
So, in the last at least few years, a lot of oxygen has been sucked out by the fact that we are now seeing a rise in colorectal cancers amongst the young. And this means patients who are below the age of 50. This increase is real. This is not imagined. The data are very strong. It suggests that the graph is on the upward trend. When you juxtapose that information with the incidence of colorectal cancer over the 50-year-olds, what we are seeing is there is actually the curve has flattened and is going down. So something has gone right in patients who are 60 and 70 and 80, and
mm,
that's what the colonoscopic screening. So it has made an impact in that group of patients. But the
mhm,
graph of the young patients going up is actually keeping colorectal cancer up there as number 3, and the data bears that out. There's a very frightening statistic that for a young person under 50 to get diagnosed with colorectal cancer, the number of physicians they have actually seen is 3 before the diagnosis was
mhm,
made. So
mhm.
physicians don't believe or
Don't
don't suspect
suspect
that young person in front of you in your clinic
we're having
could
a
have
cancer.
cancer. So by the time they order the appropriate tests, the cancer moves forward. So that's something which we are trying to educate our primary physicians. We are trying to also speak with women's health physicians, so our gynecologists, because In the under 50s, what we are actually seeing is women are more likely going to get colorectal cancer than men. Again, we don't know why, but it
Mhm.
opens an opportunity for us to actually club screening for a mammography, for a pap smear, and
Okay.
also
And
advocating for
colonoscopy.
screening for colon cancer.
Clearly, we understand now that it's a multimodality treatment for colorectal cancer, and uh, it should be mandatory that we should have a multidisciplinary approach to these patients when they come. So I want to, you know, use your presence to understand this in a case-based scenario so that, we get a sense of how you all think about when you get a patient like this. So suppose you have a 60-year-old lady with mid-rectal cancer. You've done an MRI, which is probably the standard of care for local staging, and you find it's a T3 disease with some mesorectal lymph nodes. Now, just take me through this. That, of course, you'll do a biopsy, you'll do the MMR status, and how do you now plan the treatment of this patient? What are the options, and how do you exercise these options in a particular scenario?
Yeah, great case. So, when you talk of the MDT, we really have the surgeons, we have our medical oncologists, our radiation oncologists, we have our radiologists who only read, body imaging, so they are experts in the field. The MRI of the rectum also needs specialists to actually read them, and a certain degree of specialization to perform the study too. Part of our MDT also involves our genetics counselors are always on our meetings. We also have our pathologists who will review the pathology for us. In addition, we have something called as a wellness group. So they look after patients' needs in terms of if someone has nutritional needs, if they need prehabilitation with physical therapy before a surgical procedure, or if someone is a smoker, we want them to give up, but we can't just tell
Yeah.
somebody to go cold turkey. You need to help them. And then there are also psychological issues, when especially patients who are young get cancers, we need to have some support staff to look after them. As part of our MDT, the final question on every case is also, is there any trial in which the patient could be recruited? Because we always don't want to miss an opportunity if there are clinical trials ongoing where patients can be recruited,
Yeah.
not only help us with furthering science, but they also may get better care. So that's actually the sort of standard MDT we have. A case like this would have obviously had a CT chest, abdomen, pelvis, the absence of metastatic disease. The focus would be on the MRI of the rectum. So, a mid-rectum meaning the sphincters are uninvolved. There is some mesorectal nodes, which clearly clinically would be reported as a stage 3 cancer. So, in this patient, the approach would be to consider neoadjuvant therapy. The terminology now is called total neoadjuvant therapy. It's TNT for short. So patients actually get all their chemotherapy and all their chemoradiation initially. Everything is
Okay.
done beforehand.
All
So
patients?
in a scenario like you described, yes.
Okay.
And so if I flip that a little bit, if this tumor was low rectal, and if the sphincters were closed, then the discussion in the MDT would be, should chemotherapy be done first or chemoradiation first? And the only sort of way to go about this is when you see lymph nodal disease in the mesorectum, you really want to control the disease systemically. So this patient would be started with systemic chemo first with Folfox. They would go through their entire cycle. After that, they would get chemoradiation. In a situation where the sphincters are not threatened, you could do a short course radiation. So even though you're doing TNT, you could do all your systemic chemo. We would re-image because there are patients in whom actually the tumor may completely respond to just systemic chemo. And then the question comes up whether we should do radiation or no. Standard of care is radiation,
Yes.
but there are trials where you might want to go straight to surgery, but that's within a trial. So, assuming that the tumor was much lower, then you would always do long course radiotherapy because you want to have the tumor recede away as much as possible from the sphincter muscles and increasing the chances of sphincter preservation. So that would be the sort of discussion we would have.
Yeah.
Sometimes, if the lymph nodal burden is not much, so you're not worried systemically, but you're worried locally, then we may actually do the long course chemoradiation first and then do the systemic chemo. And the rationale being that the radiation has got another 3 months of action to have, so that you actually are improving again chances of sphincter preservation.
If I understand correctly, if there is bulky disease, low disease, then you want to do long course and TNT, do complete
Correct. Yes.
therapy upfront,
Yes.
because you want to get the maximum benefit out of these modalities so as to get clear surgical margins. Am I right?
Yes, and also, there is a group of patients in whom you might actually get a complete response clinically.
Yes.
And if
Yes.
there is no tumor seen, if the tumor completely disappears, you can't palpate it, you can't see it on a flex sig, you only see a scar. On imaging, there's only thickening, there's no tumor, the diffusion MRIs are clean, then we can actually watch and wait. So there is a lot of change in the way we are treating rectal cancer. I have several patients whom we are watching and waiting. We're just sort of following them very closely. We have a very close protocol which involves every 3 months or 6 months they come into the office, they get an exam, we do a
Yeah.
flexing, they get an MRI. So you're absolutely right. The entire treatment of rectal cancer has become so nuanced that it really needs to be held done with specialists and with specialists in every specialty.
Yeah. So that complete response is that Haber-Gamma uh, approach. I mean, one of the things in that, since you brought that up, a complete response, is that most often you recommend surgery even if there is a response on imaging and on clinical examination and flag. And you would find that about 10 to 15% would still have some tumor. But there is a 85% who don't have tumor. So how sure you are that you can just adopt, wait and watch, and what is the incidence of tumor coming back in these? And then how do they fare with surgery at that point of time? Is there any difference?
That's a great question because, initially my instincts would not allow me to believe the data, because the data was strong that if you actually had a complete response,
Yes,
you could wait, and you could wait safely provided you were surveying your patients very closely.
closely.
Because in the event that you actually saw a recurrence or a residual tumor somehow which was missed, the salvage rates are equally good as when if you would have operated primarily. So it took
Yeah.
me a while to convince myself that my patients are safe with this approach. But
Yes,
having said that, if you are very closely as with your team, your radiologist is also the key. I
yes.
can remember a case very recently where the radiologist actually was nervous about calling it a complete
Complete
response.
response.
And I kept reporting back at our tumor board saying that there's nothing I can see on the flexible sigmoidoscopy. We can't feel anything. And in the past, I was easily able to feel this tumor. And the patient trusted the approach. We are now
Yes,
almost 2.5 years out. Patient is still safe, but that's like a sword hanging over us. And as responsible clinicians, we feel very vulnerable, especially if patients get a recurrence, whether we should have done this much sooner. But I have several patients, so do many of my colleagues, where we have a very close watch and wait.
So, let me share one scenario or incidents. We had somebody from our staff whose father, he also had a renal transplant and he had a rectal cancer. We treated with neoadjuvant therapy and there was complete response. I suggested no more surgery, but they were very keen for him to have surgery. They said, no, no, this is the opportunity, and multiple opinions here and there and all. And in the end, believe me, I had to forcibly do a procedure which I didn't want to do. And this patient, his recovery was marred with a lot of complications. He had a stoma, but there was a problem with the functioning of the stoma and so on. And eventually, after about 3 months, we lost him. So now, you wanted a particular approach and it didn't. And people didn't believe that complete response can be wait and watch, and they wanted to get the best out of it. So it works both ways that, the physicians
Yes,
don't want surgery, and sometimes patients are very
and
happy not to have surgery, you know. So,
they are. I think many times, and I think sometimes, we also maybe trying to oversell the fact that somebody is going to get a complete response. My own counseling with my
yeah,
patients when I speak with them is that, see, we don't know how much your tumor is going to respond. All we know is that by using this approach of TNT, we are actually improving the chances of better surgical outcomes for you
yes,
and also reducing the risk of the metastatic spread. Now, when we reach that point 6 months later, when they come back, there's no tumor. That's when you
yes,
start creating
talking to
that
them.
slight opening for avoiding surgery. And, I have patients who are very nervous about not having surgery. I would not then force them to go on to watch and wait.
Yes,
But at that moment, that counseling is very critical that, look, we may remove this section, there may be no residual cancer. You would have undergone a life-changing operation for something which maybe we could have avoided surgery.
avoid.
As long as that conversation has happened with the patient and their relatives, and they understand that this is what they want, because they are equal partners in this decision. You can make a
Absolutely,
recommendation,
absolutely.
then finally they will choose.
So the patient we were talking about, so undergoes the planned therapy as per the MDT, and there is response, at least there is no progression, and this patient would have surgery. And we know that minimal invasive is currently, if I can use the term, a standard of care. But let's get the open surgery out and understand when in your practice would you offer open surgery to patients of colorectal cancers?
So I'm not shy to do open surgery when it's needed, and I have met several surgeons, and I work with some of my partners who feel that when you do an open surgery, it's actually a defeat. It's not. It is what to do when you feel unsafe. If I'm in a situation where I'm deep in the pelvis, the minimally invasive approach is always going to give you a better approach, meaning your vision is better,
Yes,
your fields are better. You don't have to be breaking your back by bending over. You have a camera which gives you a great view. So certainly in the pelvis, when you do laparoscopic or robotic, your views are far superior. But there are restrictions,
yeah,
especially in tumors which you can't really handle and give yourself adequate retraction. There are some limitations which come into play. There are times when your vision may be impeded. You have a lot of charring or burning with your diathermy, the smoking which comes in constantly, sucking out the smoke. reducing your pneumo. Access is minimal. You're looking for the
Yes.
nerves. You're trying to get behind the vesicles. There are areas where I will not be shy if I'm not clean with my view. If I can't retract the tumor appropriately, I will not hesitate to do it open. But those are becoming rarer and rarer, those cases. There are approaches where there's a redo pelvis, then I may have a very low threshold to go open. Sometimes counterintuitive as this may sound, but in patients who are elderly, the oldest patient I did a low anterior resection was 94 years old. Uh, he was in great shape, but I did not want this guy to be in a
Yeah.
steep
This
T-berg
is
for 2 hours. I wanted this operation to be over in 2 hours. So I approached it with an open approach. Day four, day five, this gentleman left the hospital successfully. So that's how I tailor my approach.
Yeah. Yeah, I think it's a great point because I've faced this, handling the tumor and retraction is oftentimes, especially if it's a narrow pelvis, it's sometimes, and things like, right colon tumor, abutting the colon, the IV, duodenum, I mean, and the IVC, and you're wary of, dealing with it or having a mishap. So the conventional hand feel is a great thing to have. So, uh, great. I mean, I think, these are important points for people to realize it's not a defeat, but you need to horses for courses. What you want to do, you need to do. And yes, another point which you said, elderly or people with cardiac background,
Yes.
you don't want a prolonged pneumo and going in for a long time, because I recently did one lady about 80-year-old having had a gastric cancer operated and obstructed colon cancer, and we put a stent and then went in, and I just wanted to finish it quickly, a left hemicolectomy. So I think those are scenarios still warrant a open approach, and it's you need to be adept at that. Uh,
Yes, and also, there have been situations where I have been asked to help some colleagues, and they have been reluctant to give themselves adequate exposure. Working when you're open, you're open. Then
yeah,
you're not going to
yeah,
try to then make a small incision and struggle. So
correct.
also you have an open approach. Sometimes the trick is not doing the operation, it's actually how you set it up. It's how you expose, how you retract, how you
Yes,
can have your assistants help you. And
yeah,
that experience is unfortunately fading. So
yes.
when the crunch moment comes, people are struggling. They will keep persisting minimally access, and it can create havoc.
So we did talk about some of the problems now, like in minimal invasive, as you mentioned, there are some limitations and all. How do you compare the robotic platform over laparoscopic in colorectal surgeries? Just give your insight in how one scores over another and its limitations, if any.
Sure. I think both are, excellent techniques from the patient's outcome point of view. So for, creating smaller incisions for faster recovery, less pain, less hospital stay, I think they are both certainly better outcomes for these yardsticks as compared to open.
Yes,
Oncologically, we have not been able to prove superiority, but I think this is an important point in favor of minimally access surgery. When you compare lap versus robot for colorectal surgery, my only approach would be if you have access to a robot, use it because it's going to give you more functionalities. For example, if I'm doing a laparoscopic right colectomy, my default process is I will do an extracorporeal anastomosis. When I'm doing it robotically, my default process is intracorporeal. And that has certain advantages because, especially in patients who are obese, who have a shortened mesocolon, to bring it out into the
yes,
extracorporeal is not easy.
yes,
Intracorporeal is much easier. Your orientations are easier. You're
Right.
absolutely certain about how you've oriented the colon. So certainly it gives you more capabilities. I think the robotic dissection down in the deep pelvis, performing proctectomies, is unmatched. The devices they have created are so much more friendly to surgeons. And with the air seal, which really is a very high flow pneumo, supporting system, even the smoke is really hardly a problem. So
Yeah.
certainly, if you have access, that would be my recommendation. That if you were someone who was lucky enough to do either lap or robotic, then I think robotic has definite advantages over laparoscopy.
So, Parul, any limitations with robotic?
I think you have to be very facile to do multi-quadrant robotic procedures. So it's not easy to just flip the robot over. So, for example, my initial curve when you set up your robotic ports, and now I'm sort of giving you a direction of going towards the splenic flexure. It's not very easy to do that in your first few cases because you're struggling with your arms. It's when you know where to put the arms, how to dip the booms down, and of course changing the approach where going with the IMV first and then going superior to the IMV, entering over the pancreas into the lesser sac. That gives you a different capability to bring the splenic flexure down. So those are certain things which can be cumbersome for surgeons when you're doing robotic. The other thing is in robotic procedures, you're very close to your target. The camera is really close. So it does not give you a perspective of what is
Yeah.
happening around you.
Around.
In laparoscopy, very easy to bring your camera
Bring it down.
back. You're not sure. And also, some of the mishaps which I have seen in robotic procedures are the instrument changes which are happening outside your vision.
And even
And
the
that's why.
assistant ports which are functioning,
Yes.
they're not
So
under
you
vision.
really want, when instruments are moving in and out, you want to really come back with your robotic port, make sure what you're seeing, because that's where I have seen certain mishaps which have been pretty bad.
Yeah. I How about I feel sometimes in patients retracting the bowel becomes a problem. In laparoscopy, you can always put an extra port and use it, but robotic, you are limited. And I've had occasions when I would change from robotic to laparoscopic because this part is coming in the way all the time and I'm not getting the access to function. Is it something which bothers you also?
It used to. I think, in the early cases, I also used to go into more extreme positions just to have gravity aid my retraction. But of late, I find just minimal, for example, right side up for a right colectomy, just minimal right side up, a little bit of Trendelenburg is enough. Earlier, I used to do much more extremes. Um, Having said that, even when you do robotic, I always put an assist port. I will have so one port where the assistant can either put a bowel grasper or a suction device and give me that additional capabilities. You work through that, but you're right that retraction can be an issue. Sometimes very, cleverly through the 12 millimeter port, you can actually put in a gauze, and then the gauze acts like just with its
Yeah,
weight becomes a retractor.
yeah. We have this ICG Firefly thing with robot, and it is touted as something which, would help you look at the vascularity and then minimize the risk of leakages and failure of anastomosis. So, what do you think about this ICG and its use, and has it really made a difference, or it's a good tool to have, but you will still leak if it has to leak? What do you
So
think?
the data is mixed, but there is a growing body of evidence and opinion. Let me also put it that way, that ICG is going to be very helpful. I think it's a very simple tool to use
Yes.
if you have the appropriate cameras to look at the fluorescence. Um, I find that people who are using it routinely use it, as a sort of crutch, or they want to base their resection margins and their anastomosis on it. I have a more pragmatic approach. I would certainly not discount its use, but I'm not obsessing over it. I
Right.
think when I have the normal view on the bowel, and if the colon edges are bleeding, if there's no tension, I'm fairly relaxed that this is going to be a safe outcome. I might endorse my
Yes.
clinic view with the ICG, but one worry I have, Sadiq, is that what's going to happen is, as more data comes in and as more surgeons get used to it, it will somehow make itself a standard of care. And, especially in societies where
Yes.
litigation is a
Litigation.
problem, you might want to document that I did
Yeah.
this study,
Yes.
because
Absolutely.
lack of doing the study means you did not really confirm that there was adequate vascular supply. So I don't know where this is going to head in a few
Yeah.
years, but I think the more you do it, it's likely you're going to be part of standard of care.
Yeah. Yeah. I mean, I agree because your clinical assessment or operative assessment invariably is akin to what you see on ICG. This is what I have found in years of experience. But I think it's a great tool to document, and at least to say that, there's objective documentation of what you have. Yeah. Uh, I remember you said you were the one of the pioneers for laparoscopic bowel surgery in India, and I remember one demonstration which I watched of yours, and you showed the technique of getting into the splenic flexure by lifting the mesentery, pancreas, and this. So, I mean, I still remember that, and when I do it, I say, "Oh, Parul has showed this to me." Uh, so, any other technical tips, like, say, for example, how do you ensure uh, nerve sparing? How do you ensure that? Sometimes there's a problem in low rectal cancers of the colon going down. So, what tricks you have, or you know, techniques you
So,
have to get
so
through to this?
certainly my adoption of splenic flexure mobilization, I would say, is almost close to 100%. There's not a single case where uh, if you have an extremely redundant left
Yeah,
colon, which is
yeah.
just sort of falling into the area
Yes,
of the
yes,
anastomosis, is very different. But I will never hesitate to get the splenic flexure mobilized. I think that's the key to avoiding tension on the anastomosis. I think getting the nerves, the key is to actually identify the IMA. So the my standard default way is to go for IMV, and I must acknowledge that this is something I really learned observing with Son Han Kim, in Korea. He's been a great teacher and mentor to hundreds of us. But when I watched him do that, I was like, why am I not doing it myself? So I started doing that. But once you get the IMV taken and you come inferiorly towards the IMA, and as you get behind the IMA, that's really the point where the nerves start making an appearance. And if you can stick very close on your total mesorectal excision on the posterior, follow the IMA down into the deep pelvis, you're going to keep your nerves safe. So that's the key. Keep with the artery, keep in the right plane, make sure that you visualize the nerves fairly proximal, and then as you go distal, they become more and more clear. And as the IMA is taken, you clearly spy the left ureter. Once you've seen the left ureter, again, it becomes more and more safe for you to start making those entries into the pelvis. I think in males, one has to be careful as you do your posterolateral and then come onto the anterior side. I find surgeons let their guard down when they're coming into the, I would say, 2 o'clock and 10 o'clock positions anteriorly. where again you want to be very cognizant the vesicles, dropping it down the rectum.
Yeah,
Also,
get into the
if
right
you
plane. Yeah.
yes, and if you have an anterior tumor, you want to get into the fascia of Denonville, has to come down. So there are certain technical challenges, and it all comes down to studying the case. For colon, I'm very sure that the mesocolic
Yes,
excision should
totally.
be tried. If you can get into the right planes, keep that envelope intact. Sometimes the development of the medial to lateral approach really has changed the way we see anatomy.
Yes,
And I think that is has given us all these planes. So that would be my technical tip. Always try to mobilize very adequately. Don't
yes.
take a chance. If in surgery you take a chance, you're going to be in trouble. You're going to have to come back within the next few days to reoperate.
So one thing always worries me, or I keep on thinking about when doing rectal surgery, and say especially for upper rectal surgery. Uh, I'm a little hesitant in taking an IMA in that. So I do the node dissection of all the IMA and then leave the IMA so that I ensure good supply to it. And I always think of that in HPB surgery, when we are doing node dissection, we don't sacrifice the right hepatic because we have to clear the lymphatics. So why we are so generous with uh, taking off the IMA just to clear up everything. I don't know what you feel. Always take IMA, or you could do the dissection.
I would say most of the time I would do that. And again, it's all again linked to the length, because your comparison, of course, with the hepatic artery, as you know, is so unfair because you really don't want to devascularize the liver, but the rectal side is reasonably well perfused. Even if you go for a LAR. But I get your point. I think a lot of surgeons I think, look, my uh, approach would be if you're meeting the minimum lymph node numbers for adequate staging, that's what you need. That's
Yes,
that's exact. That's what you want. You don't want to, do an operation where you don't have an adequate stage. So,
yes.
12 to 15 nodes, if you're getting with the approach you are doing, you're doing the right thing.
So, just getting to the brass tacks, like, the practical issues. So, you do a low anterior section. Uh, how often do you do a stoma in this era of neoadjuvant therapy? Uh, and when would you not do a stoma? Either way.
So, the classic, obviously, there are groups which will say we do an ileostomy 100% of the times. There are surgeons I've heard, and I don't know if it's true. They'll say I never do an ileostomy or a covering colostomy.
Yes,
I'm clearly in the middle. I think if patients have had radiation, if your anastomosis is low, you're going to do a disservice to the patient by not protecting that anastomosis because a leak happening there, you're really going to deal with tremendous difficulties in salvaging good function.
yes,
So my approach is if I have uh, a very good anastomosis, which is reasonably high, I'm absolutely sure that I have no tension. The donuts are great. Vascularity is great. I will not do an ileostomy. But the minute I'm in a radiated field, I will rethink. I will always ask myself, is it necessary to do it? If
yeah,
it is, if that it comes in my mind whether to do an ileostomy,
it
I'm
needs
likely going to do it.
to do it. No, I think, you hit the nail because if you are thinking about a stoma, then that means you need a stoma, for that patient. Yeah, I mean, I
So
think,
one other, rule of thumb, and it's not easy to apply, is that your diverting stoma rate should be equal to your leak rate. But nowadays, our leak rates are very low.
low,
So
very
it would
low.
be a very low stoma rate. So I think I can't apply that currently to
Yeah,
my. I'm sure my stoma rate is higher than my leak rate.
yes, yes. Yeah, that's interesting because most of the time we don't do early studies if you have a stoma, and we don't know that early leaks have healed off by the time you close that.
Yes.
So unless you do regularly that, you would know really how often the stoma is benefiting. So when people see it at a later point and they say, oh, anastomosis healed well, maybe they didn't need, but that's not the correct picture, right?
Right.
Yeah. So we are talking of low anastomosis. Now I want to pick your brains on what about intersphincteric resections, both in terms of the oncological outcomes and the functional outcomes. What is your, from your experience, huge experience of doing this over a long period of time, how would you put this in perspective?
So, again, data suggests that functionalities of doing of an intersphincteric resection or a very low resection after radiation is not going to be as good as normal function. Patients are going to have what is described as a low anterior resection syndrome. So certainly, function is a problem. Uh,
Distressing
it
scenario.
is. It is. Uh, But having said that, quality of life with a functional anal area is superior to having a colostomy. It's only when you become a cripple because of very poor function. If someone has had a leak, if you've had a great degree of scarring in the anastomosis, then your function is even worse.
Yes,
So there are patients who will lose continence because they will constantly be leaking. There'll be people who wake up in the night 10 times to go to the bathroom. Those patients are better off with a permanent ostomy. So certainly it's a very critical decision making. Many of my patients have low anterior resection syndrome.
right. Wow, it's been great experience speaking to you and picking your brain on that. Uh, it has to come to an end. Let me ask you, Parul, that, as I said in the beginning, that why colorectal surgery you took up. Uh, I always feel that, the whole challenge of colorectal surgery is the specter of an anastomotic leak, which sort of, hangs on your head all the time when you do an anastomosis. So, if you are advising people to take the specialty of colorectal surgery, what would you say to them? A, should they take it up? B, how should they sort of mold their training so as to be adept at doing or focusing on colorectal surgery? What is essential for their training?
So certainly there's a lot of excitement, in colorectal surgery. This, as I said, it's a cancer which can be treated so well, especially when it's detected early. I think all this technology which is being used, we mentioned ICG and the robot and the colonoscopic tools. Very few specialties have so much development happening. So I would certainly encourage people to do this. Just imagine as the incidence of colorectal cancer rises in the rest of the world, and it will, unfortunately, we will need more trained surgeons to deal with this cancer. I think we'll need more surgeons to be trained in endoscopic techniques. And this is, right now we are talking of surgery which we have been doing since, I don't know, since maybe 100 years, where you see a tumor and you cut a pore section out and then you connect it. But if you just project into the future, even maybe 10, 20 years, it's likely that those tumors will be just removed colonoscopically. We may be able to inject some chemotherapy in the bed. We might be able to actually use needles to ablate lymph nodes. So if you just project, there's so much going to happen. And
Mm.
all of that is only going to happen if surgeons come into the field. because the intersection of endoscopy, interventional radiology, and surgery, that's where bowel surgery is going to go. So, as GI surgeons, that's we want to lead that. We have the imagination, we have the capability of leading that. So I would certainly ask every young surgeon who has interest in treating abdominal cancers to actually think of treating colorectal cancer.
So you suggest for them to have, after their training, a specific fellowship exposure for, you know, specifically to go and train in this areas where there is high volume work. Is that mandatory? Uh, how should they go about doing it?
I think certainly training, where specialization exists, expertise exists, and also high volume, because you need an intersection of all these three aspects. Because doing an occasional case, really, you're not going to get a feel of what this all is about. And it's only when it becomes very repetitive, very monotonous for you, but it remains exciting for somebody who's watching it from the outside. That's when you know that you're really a specialist. But having said that, every single case we do is different to the previous case and the case to come,
Yes,
and once you feel that I have mastered this technique, that's the beginning of your problems.
yes, yes,
And that's why I think all of us surgeons are innovators in our own. We try to get by difficult situations. We will find a way, but only thing is when you take shortcuts or you don't do your due diligence, then patients
yes.
pay a heavy price. And I think we have to guard against that. We have to be very true to the outcomes we want.
Thank you very much, Parul. It is very generous of you to spend this time on this podcast, and I'm really happy to have you on this. I hope we could sit together again and discuss many more aspects of colorectal cancer, but let's leave it for another day, another time. Thank you very much.
Thank you.